name is Dr. June Young. I'm an endocrinologist researcher. I'm the head of the Endocrine Hypertension Group at Hudson Institute of Medical Research in Victoria, Australia. I'm also an associate professor in the Department of Medicine at Monash University and a consultant endocrinologist at Monash Health. I studied medicine at Monash University in Australia and was inspired by my mentors to pursue a PhD in the signalling pathways of aldosterone, which is a hormone made by the adrenal glands. Whilst that PhD project was entirely based in the laboratory, my PhD supervisor at the time tapped me on the shoulder and said, "Have you thought about primary aldosteronism, which is a clinical condition where there is too much aldosterone being made by the adrenal glands?" We knew that primary aldosteronism was an important condition, but there were no hospital guidelines for it. And so I took on this new challenge of setting up hospital-based guidelines. But little did I know I would find that this condition is far more common than was taught at the time. And there was a huge need for increased awareness and guideline changes so that patients who are affected by this condition can benefit from an accurate diagnosis and treatment. And from there, I moved my research direction to a more clinical translational research angle and focused on what I can do to increase the detection and improve the management of this disease for people in Australia and around the world. At the moment, I lead the Endocrine Hypertension Group, so our focus is on diagnosing and treating hormone causes of hypertension, in particular primary aldosteronism. And the four main elements of our research include improved detection, improved diagnosis, better management, and just understanding this condition at a population level to appreciate the public health impact of this disease if it's untreated. My work currently involves collaborations with general practitioners who are really at the front line of hypertension management, in addition to specialists around Australia who manage high blood pressure. Furthermore, this work has taken me overseas to collaborate with laboratories and research groups in almost all continents, because primary aldosteronism is an international problem. As highlighted by the Primary Aldosteronism Foundation, which is a patient-driven consumer advocacy group, there is huge injustice being done to the patients. If 1 in 10 patients with high blood pressure have this disease, and yet only 1 in 1,000 or less are currently being diagnosed, there are a lot of people walking out there with a potentially curable disease. So I'm very pleased that the work that we're doing now has started to have impact at raising awareness in primary care. Now that I'm on the International Primary Aldosteronism Guideline Committee, we really hope that the next set of guidelines will advocate for screening all hypertensive patients at the start of their disease, rather than waiting for end organ damage to occur. I'm passionate about the research that I'm doing because of the collaborations that I have with patients who are affected by this disease. Primary aldosteronism may seem like a silent condition, it just causes high blood pressure. But the high blood pressure is extraordinarily difficult to control using normal medications. Furthermore, patients with primary aldosteronism are at much higher risk of stroke, heart attack, irregular heartbeat, kidney failure. And yet a lot of these patients do not receive a timely diagnosis. We recently conducted a survey of over 600 patients with primary aldosteronism, and the overwhelming sentiment was that there is a delay in their diagnosis, and often they're told by their doctors that their blood pressure is just the way it is and to live with it. But in fact, many of them, or all of them, because they're all patients with a diagnosis, have an underlying cause that has specific targeted treatment and a potential cure. So I'm motivated by the desire to help these people around the world so that in the near future, everyone who suffers from primary aldosteronism can receive a timely and accurate diagnosis. And I guess an additional unexpected motivation for doing the research came about during my research when I diagnosed both of my parents with primary aldosteronism. And looking back in my family history, I'm pretty certain my grandfather died of a hypertensive stroke that was probably related to primary aldosteronism. So now I'm a consumer as well as a researcher. I'm the mother of 3 boys, so outside of work I'm pretty busy just looking after these boys. Cooking, driving, all the things that mothers usually do. But we love to go to the outdoors, we go camping, hiking. In fact, next week I will be hiking 30 kilometres to raise money for the Heart Foundation as part of Coast Track. I'm also a Joey Scout leader at the First Glenaris Scouting Group, which is in Melbourne. I look after a group of around 20 Joey Scouts aged 5.5 to 7. It's just a lot of fun to hang out with them and to teach them things. And they're certainly a lot more obliging than some of the older people that I have to work with.